Next, I call upon Dr. Pabitra Kumar Sahoo.
My talk is on pressure ulcer management. This is a very common complication everybody will come across in your clinical practice. There are so many terminology are there for describing pressure ulcer, like pressure injury, pressure sore, bed sore, or decubitus ulcer. Basically, these are localized injury to the skin and underlying tissue, usually over bony prominences, are as a result of pressure or in combination of the shear or friction. The global prevalence rate is around 11.3 per 1 lakh, and most commonly seen in spinal cord injury patients, around 32.36% prevalence rate. In stroke patient, it is around 8.3%. So really this is a concern because this add morbidity to the spinal cord injury patient. Unless if you get patient like this with a huge pressure ulcer, no therapist or nobody is going to touch him. Neither a patient can go to any other places, or neither any plastic surgeon interested to manage this type of cases. So it's a whole responsibility of us to manage this situation. So the location of pressure also depends upon the mobility of the patient. If the patient is confined to the bed, or the patient is in proper position, or patient is wheelchair mobile, that decides where the pressure also develops. However, 70% of cases, the locations are over the major bony prominences like sacral area, bilateral trochanter area, bilateral scale area, especially for wheelchair movers. Sometimes you get pressure ulcers in very uncommon sites also. We receive this type of cases like having pressure ulcer over the natal cleft, pressure ulcer over the abdomen. You will see also, like this patient received recently, and you can see pressure ulcers over the calf area. Sometimes patients have pressure ulcer over the plantar surface when the patient is moving on a wheelchair because of pressure from the footboard of the wheelchair. And you may get pressure ulcer over the knee also as a kissing ulcer bilaterally over the anteromedial aspect of the knee. Pathophysiology already described by Dr. Matthew. I don't think I should not waste time on that. And regarding staging of the ulcer, you all are final year residents, you must be knowing this. But one point need to be highlighted is that this pressure ulcer terminology has changed to pressure injury in 2016 by the NPUAP board along with their stakeholders. They saw that there is a difference between ulcer and injury, because this stage 1 ulcer is not conforming to criteria of ulcer. For any ulcer, there must be any breach in the epithelial surface or any surface breach. But in stage 1, we don't have any breach in the continuity of the skin. So they have changed that to instead of ulcer, it is pressure injury. And stage 5 also included in that. There are certain risk factors which adds to the increased incidence of pressure injury, like spasticity and contractures, cognitive impairments, impairment of nutrition, especially anemia, low BMI, and there is significant illness and comorbidities like diabetic mellitus, or patients already in hypoproteinemia, low immunity status. All these things should be taken care of when you plan for any management of pressure ulcer, pressure injury. You must know also how to assess a pressure injury. There are different scales are there for assessing the pressure injury. These scales are especially used for your research purpose or documentation purpose. However, for clinical purpose, you must know how to evaluate, how to assess a pressure ulcer, pressure injury, especially where is the site, size, like length and width, depth of the pressure ulcer, ages, whether it is undermining or white, inverted or everted, red color or is whitish in nature, type of floor filled up with granulation tissue or necrotic tissue, what type of necrotic tissue, amount of exudates coming out of pressure ulcer, then color of the skin surrounding wound is very most important, but that shows aggressiveness of the ulcer, peripheral tissue edema and induration, granulation tissue, epithelialization. There are two tools very commonly used for this pressure ulcer evaluation. One is a pressure sore status tool, and another is a push score. This PSST, this provides objective data for wound evaluation in pressure injury. This one, the pressure ulcer scale for healing is advised by NPUAP, and this also includes the parameters like size of the wound, amount of exudate coming out of the wound, and type of tissue it is on the floor of the ulcer. This scale helps in quantifying the healing progress of the ulcer. A decrease in push score over time indicates the ulcer is healing. Now coming to investigation, before planning for any surgical management, you have to thoroughly evaluate the patient as far as the blood parameter is concerned. You should look for any underlying inflammatory process is going or not. That's by recording CBC, ESR, CRP. Yes, hemoglobin status is very important. You have to tackle anemia before planning for any further management. Nutritional status, that includes serum albumin, total protein, transferrin, and creatinine. These are very important. Many times you see that the ulcer is not healing. Even if you go for a quick cover of the pressure ulcer with a split thickness graft, the donor site will not heal. Even though recipient site closed, but the donor site will not heal. That's because of the poor nutritional status of the patient. So that has to be corrected, and you have to assess that before planning for any form of definite treatment. Radiological investigations and tissue cultures are especially reserved for stage 4 pressure ulcers. When you expect a underlying bone affection or chronic osteomyelitis is there, that you have to take X-ray for any sort of stage 4 pressure ulcer management. Many times we depends upon on the culture of the secretions. No, that's not enough. Many times you will find culture sensitive to negative, but the tissue culture will be positive because of formation of biofilm. So it's mandatory when you plan for any sort of debridement, take a tissue for culture sensitive test rather than depending on the culture sensitivity of the secretions. Management, as far as concerned, yes, the gold standard, the measured pressure ulcer, they heal with conservative treatment, and conservative treatment is the first modalities of management unless you are dealing with a stage 4 pressure ulcer. So for that conservative management, a good skill for debridement, proper debridement, and a proper wound care is very important. Yes, surgery is important, but surgery allows only rapid resolution of the ulcer. But be sure before jumping to the surgical treatment, see what is happening, why the pressure ulcer is not responding to your conservative management. A poorly healing wound should first be assessed for why the wound is not closing, what is the factor underlying to why it is not healing. Then the same factor can be a major failure factor for your surgical reconstruction. So before planning for any conservative to switch to conservative surgical treatment, look for what is the underlying factor which is preventing the conservative closure of the pressure ulcer. This management spectrum ranges from conservative to surgical closure. So conservative is the first, as I said, and you should first look at what is the cause. The main cause is the pressure. So you should try for relieving the pressure. There are different bed mattresses are available. We will discuss in subsequent slides what are the bed mattresses available. And the most important part is bed position, positioning the bed. Every 2 hours patient should change his position. That has to be ensured by the caregivers or by the patient himself. And the patient is moving in wheelchair, ensure that patient is going for the weight relieving measures. Every 15 minutes the patient should go for some sort of pressure relieving, whether push up, forward leaning, backward leaning, sideways, every 15 minutes for 15 seconds to avoid pressure ulcer over the ischial area. The next part is once the pressure ulcer develops and is progressed to stage 3 or stage 4, a rapid debridement is essential to take out all necrotic tissue and to remove the biofilm. That's very essential. The biofilm is such a thing that whatever antibiotics will give, it will not reach to the site. That will always prevent antibiotics to reach to the site. So that can be excised with a proper debridement. Control of infection with the proper dressing, topical application of biological agents, and negative pressure wound therapy. Certain adjuvant physical therapy also helps in reducing the time of pressure healing, and optimize the medical status, especially nutritional status, anemia, hydration, and try to eliminate the underlying risk factor which is causing pressure, giving a hindrance to the pressure ulcer healing. So, and the last stage is the when it is not responding, you have to go for surgical closure. So, let's see what evidence says about the all these components as far as the conservative management is concerned. So, as I said, the first part is the relieving the pressure. That's the cause of developing pressure injury. So, that can be managed by using different type of beds and mattresses. The commonest mattress we use in clinical practice are the foam mattress. Others use reactive or active air surfaces, reactive water, reactive gel surfaces. But this is a study Cochrane review. This is a network meta-analysis where the outcome measures taken were incidence of a new ulcer formation and ulcer healing, and different papers considered in this systematic review. They have compared the foam surface versus reactive air surfaces, foam surfaces versus reactive gel surfaces, and their result says that the best surface used for the prevention of pressure ulcer or fastening the pressure healing is the active air surfaces, which really is not available in every centers, and this is better than a reactive air surfaces, and which is again better than a foam surface which we commonly use in our clinical practice. There are also papers which comparing the between the reactive air surface versus reactive gel. We all have an idea that gel surface has a better pressure relieving effect, but this study says that there is not much difference between using a air surface or a gel surface. The next component is debridement. Once the pressures progresses to stage 2 or stage 3, then debridement is must. To accelerate the healing process, there are different methods of debridement like autolytic, chemical debridement, mechanical debridement, biological and surgical debridements. But regular debridement is very essential. Everybody must learn to skill of a good debridement. This debridement converts a chronic wound to a acute wound, thereby it initiates the healing process by releasing the inflammatory mediators and releasing the growth factors at the site of injury. But this surgical debridement also very important when the bed surface is well covered with this purulent necrotic tissue or necrotic material, and subsequently you can use enzymatic or autolytic debridement for minimal necrosis, or it can be used as a adjunct procedure after your surgical debridement. The third one is the dressing. What dressing we are following in our department? Gauze, especially we normally in our department we all follow this wet to dry dressing using a normal gauze. So you apply, because all wounds they prefer a moist environment for healing. So you apply moist gauze, and when you take out the gauze, when it is dry after 24 hours, then all the necrotic tissue will come out through the dry gauze. That's the way to dry dressing. And others people use paraffin gauze, hydrogel, hydrocolloid, polyurethane adhesives, different dressings, fancy dressings are available. But what are the best dressing for a ulcer beyond grade 2 level? The best dressing should be impermeable to the bacteria, provide a moist environment, and it should be easily removed and keep the periphery wound area dry. So it should be occlusive or a semi-occlusive dressing, and should be non-adhesive to the wound surface. So depending upon amount of exudate coming out of wound, you have to prefer your type of dressing. If the moderate, the superficial or low exudates are coming, you can simply use a normal hydrocolloids or any type of hydrophilic dressing gels like things. If there is wound is very much exudating, high exudating wounds, you have to choose foam, something like that will absorb the exudates. And in case of very deep cavity ulcers, you can use also some amount of calcium arginate packing like things. You have to give the packing to that part so that there will be no more collection of the secretions, which can be a medium for the growth of the bacteria. But there are studies show that the best way of this type of topical dressing is the hydrogel or hydrocolloids. They have showed best evidence for ulcer healing, because these are all water suspended, insoluble and hydrophilic synthetic polymers that has affinity to attach to the bacterial cell wall, that causes bacterial cell wall destruction by thereby controlling the infection. However, this type of dressing materials are not available in all centers. There are studies shows that application of some people prefer to application of some drugs to deliver locally by applying some chloramphenicol or like rifampicin powders applying over the wound for dressing purpose. Papers also shows application sildenafil tablets grinding and putting over the ulcer area that helps in vasodilatation, angiogenesis and epithelialization. There are biological therapies are also tried with like PRP or autologous stem cells, which releases growth factor over the site of pressure ulcer that accelerates the healing process. Antibiotic beads are very much helpful, especially when you are dealing with a stage 4 pressure ulcer extending to the bone, necrotic bone. You know, once the bone is affected, it's very difficult to eradicate the infection. They develop biofilms over this bony areas, where the trochanter or ischial area or the over the sacral area, and this biofilm prevents any type of antibiotics we prescribe orally or parenterally that will not reach to the site of necrosis, that's over the bone. So this can be only manageable by applying something where the antibiotics can be released locally. That's why application of antibiotic beads. But antibiotic beads are used in other orthopedics procedure. They are all bone cement beads which has to be taken out. Here the most commonly preferable beads can be used are the stimulant, which are made up of calcium sulfate. Those beads do not require to remove it out. They releases antibiotics for a prolonged period at the local site, thereby controlling the infection. Negative pressure wound therapy is coming in a big way for management of pressure injury. This especially indicated for highly exudated wounds that helps in reducing the number of dressings every day or every alternate day, and this also seals the wound contamination from the periphery, especially when dealing with a ischial pressure so very close to anal canal. Every chance of contamination is there. If you put a negative pressure wound therapy, you have to seal the wound and this contamination can be prevented. And it also helps in angiogenesis and early quick filling of the cavity with granulation tissue. And there are studies there. This meta-analysis from the Cochrane Library shows also favors the use of this negative pressure wound therapy. But the NICE guideline of 2014 and 2018, they are not recommending for healing of the pressure ulcer as far as NPW is concerned. They are suggesting it's for just to reduce the number of dressing, and this WHS guidelines also they suggest use for filling up the cavity with the granulation tissue. And one more paper published on close incision negative pressure wound therapy. If you are going for a surgical closure, you might face a lot of tension at the wound site. If you can apply over the close wound also, negative pressure wound therapy can be applied. That reduces C demand, that reduces the tension over the suture site, thereby helping the healing of your flap or your wound coverage. Yes, there are a number of physical modalities there in the basket for helping in reducing the ulcer size in pressure injury management, like low level laser, ultraviolet rays. People are using that, but there are evidences are quite low as far as this modality is concerned when they are compared with either a placebo or a sham therapy or a conventional therapy. So these are these things are only helpful for reducing the pressure ulcer size, not for the healing of the ulcer. So next part is the surgical reconstruction by flap. This is reserved for the stage 4 pressure ulcers. As I said earlier, always we should try to manage conservatively till the pressure ulcer is up to stage 3. The advantage of surgical closure is that it provides a durable and tension-free coverage. It protects underlying structures, distributes pressure away from the affected area. It reduces pressure injury recurrences. But what type of procedure you will do depends upon the location of the pressure ulcer, size and depth of the pressure ulcer, degree of the pressure ulcer, flexibility of the surrounding tissue, and underlying comorbidities. So accordingly, there are different types of flaps there to covering the pressure injury, like local flap, regional flap, perforator based flap, or free flaps. Local flaps are random flaps. We all can do this type of flaps. These are based on nearby axial vessels. These are rotation flaps or transposition flaps or advancement flaps. Regional flaps also it can be easily done. These are basically depends upon the a regional major artery where the pedicle lies, and these are all fasciocutaneous flaps or musculocutaneous flaps. Sometimes when you planning to cover a larger defect, you cannot rely on a single artery. You can depend on the perforator based flaps like island flaps or propeller flaps. Free flaps are mostly done by plastic surgeons because that requires microvascular surgery. So these three local flap, regional flaps or perforator flaps, this can be very well can be done by all of us. So what are the arteries which we depend on the flap closure for the sacral closure? Basically superior gluteal artery or inferior gluteal artery. For ischial pressure source, we depends upon the inferior gluteal artery, or we depends upon this medial circumflex femoral artery. For trochanteric artery also depends upon femoral profunda femoris or the medial circumflex femoral artery. This is the paper we have published long back on management of sacral pressure sore by clinically isolated supragluteal artery perforators. You can check ultrasound basis, locate the perforator, locate the artery, and you can design your flap. Or else you can, if you know the anatomical landmark also, just locate the artery by the anatomical landmark, and accordingly you can prepare your flap. Certain technical things one should taken care of or should understand before planning for surgical closure. As I said earlier, is that aggressive debridement. That's the foremost part. Whether to we choose for a conservative management or surgical management, the first stage of aggressive debridement is very important. This can be done at the bedside also. Just go on excising the necrotic tissue till the microbleeding starts. And if you are taking to the OT also, that's fine. You can go to further extent to excise all necrotic tissue, all non-remaining tissue. That's the keystone. That's the key point for future healing of your ulcer. Then tissue culture and antibiotics, as I said, don't rely on the culture sensitivity of the secretions only. So when you are going for debridement, send a piece of tissue for culture sensitive tests for appropriate antibiotics for your next procedure. Use a well vascularized flap. That your flap design should be based on a definite artery, and when you closure, tension free flap reconstruction should be done. First reconstruct your flap first, then close the donor site. Meticulous hemostasis is important to prevent hematoma formation. As you know, hematoma is a good culture medium for the growth of the bacteria. So it should be closed with a suction drain to remove all hematoma or blood behind the flap, and post-operative positioning is also important. This is how we should go for the good debridement. Patient receive like this, excise the first stage. This up to this you can excise on the bedside once, and these sacral ligaments are there. Don't lose your patience. Go on debriding every alternate day, every 3-4 days interval till you get a good granulation tissue on the floor. There are certain risk factors for flap surgery like low hemoglobin level, serum albumin less than 2.5 gram %, serum creatine less than more than 2 milligram per deciliter, or associated with sepsis. You are dealing with a elderly age person, smoking, diabetes, obesity. All these things you should taken care of when plan, especially when you plan for any surgical like this. If you receive this type of pressure ulcer, so unless you excise it very thoroughly, these patients are likely to have this present with some form of sepsis. So this patient should be good debridement should be done, and the infection should be well controlled. Take a piece of tissue for the culture sensitivity before planning for a definite closure. There are certain post-operative complications also, like hematoma, that can be prevented by putting a drain, and you should don't remove the drain before 72 hours. Wound infections and dehiscence are possible. Like this patient we have done a TFL flap. Unfortunately, because the spasticity, patient was lying every time with hip in adducted position. So you know, this adducted position, the muscle, the TFL is very taut position and leading to a wound dehiscence. That can be from the infection also. Flap necrosis is possible. Fistula formation, recurrence. This is a patient we have done this ischial pressure also coverage on 6th or 7th days because of family emergency. He went home, and when he came back after 12 days, 14 days, all complete flap is dehiscence from its site of reconstruction. So these are possible complications we expect. There will be wound dehiscence over here. So this is a propellar flap, island flap. This is again because of premature weight bearing at the over the site. Yes, but with adequate care, nothing to be disheartened, it will heal. And most important part, even it recurs also. You see, this is site of pressure bearing area. So if there are at all any dehiscence of wound, it will be away from the pressure bearing area. So nothing to be worried about that. You cover the pressure bearing area, rest part will take care of by the biology. The post-operative protocol should be strictly followed. Avoid wound contamination by properly sealing the wound. Remove the drain only after 3 days. Complete rest for 6 weeks to allow flap for good healing. Intermittent sitting is allowed for 4 to 6 hours after 6 to 8 weeks of surgery. Strict adherence to the change of bed posture. All your effort will go to vain if the post-operative protocols are not followed. The patient is going for premature weight bearing. This is sacral pressure ulcers. The options are, we have superior gluteal artery perforator based flap or VY advancement flap, limber flap. These are options for covering sacral pressure. So this is superior gluteal artery based flap, can be easily cover. So another case with superior gluteal artery perforator based flap. This is another one. Small flaps can be very well covered with a limber flap. Yes, sometimes when the patient presents multiple pressure ulcers, patient is profusely losing protein and patient is going to hypoproteinemia and anemia. You have to, by emergency basis, you have to cover 1 or 2 with the split thickness graft. I know split thickness graft is not a good option for covering pressure ulcer, but yes, for emergency to prevent protein loss, you have to cover the some wounds with a split thickness graft, and by that you will prevent loss of proteins. At the same time also, if the pressure ulcer recur, you have preserved the areas, healthy areas in for future purpose for the flap reconstruction. Yes, that is the option. You can go for temporarily closure with split thickness graft. This ischial pressure ulcer looks very benign from outside, but these are very dangerous ulcers. Looks very small stoma outside, but really they are massive necrosis underlying it. And they can be managed by VY flap or island flap. You can go for primary closure also, but thing is that every time you close it, subsequent after a few weeks it will break. So this is VY advancement of management of ischial ulcers. This is another VY management after 6 months of follow-up. This trochanter ulcer we normally manage with this is TFL flap or inferior gluteal artery random rotation flap. This is one case with this flap with trochanter ulcer with tensor fasciolata flap. This is after a 6 month follow-up. This is the same patient, the opposite side trochanter flap. But here one thing should be taken care of is that this artery you will expect from 8 to 10 cm from the anterior superior iliac spine. So be ensure that you should not cross that boundary line, otherwise you will damage the perforator. This is interesting case present to us with 11 pressure ulcers over both anterior superior iliac spine, over both trochanter, over both knee, and over the sacral area, over the both heel. So this patient we manage with bilateral trochanter flap with a TFL flap, and with sacral area by split thickness graft, rotation flap for the knee pressure ulcer, and one side with secondary healing, both heel ulcer with secondary healing. And the patient reported in a very morbid condition. You can see the now patient is very much comfortable and he can be transported in a wheelchair. So my take home message is that evaluate the ulcer and evaluate the risk factors before planning for any sort of pressure ulcer management. Good debridement is very essential. You must learn the skill of a good debridement and definite dressing procedures for different type of wounds. Try to heal the wound conservatively always, because every chance the ulcer may recur. So when you fail to manage it conservatively, then you can think about the surgical closure. Of course, not for the grade 4 ulcers. Learn the skill of surgical closure. Each time patient cannot move from door to door, neither any plastic surgeon is interested to this manage this type of patient, nor patient can go to any other department for therapy purpose if he is having a large pressure ulcers. And please don't forget to go for patient counselor. It's very important to prevent the complication, post-operative complication, to prevent recurrence of the ulcer. The counseling of the patient is very important. Today you have all your effort will go to when patient has to go for a strict follow-up of this pressure relieving procedures, change of posture on the bed. These are very, very important to prevent ulcer formation. Thank you very much.
Thank you, Dr. Pabitra Kumar Sahoo, for a structured presentation on pressure ulcers. Sir is an expert in the surgical management of pressure ulcers. So if you have any doubts, you can now ask.
Sir, what is the protocol for return to sitting of a patient with ischial tuberosity pressure injury?
As I shown in my slide, that minimum to allow the patient to sit over the operated area with a ischial pressure. So minimum 8 weeks period you should wait, and even after 8 weeks period also you have to adequately counsel the patient that go for pressure relieving procedures every 15 minutes, 15-second pressure relieving procedures should be advised.
So wheelchair ambulation should not be done till 8 weeks?
No. Patient should not be allowed to sit on the bed even. Okay. He has to lie in the prone position.
Some articles were suggesting after first week we can start 15-minute, 30-minute pressure.
I just show you the picture that after 6 days patient went home, that what happened to that ulcer.
Yes, sir. Thank you, sir.
Yes.
Thanks, Pavitra. I came towards the end, but I have no doubts about your surgical skills. May I just make one suggestion?
Yes, please.
Sitting a person, your question was whether you can sit a person, how soon you can sit a person. Depends on where you are. If you are in a place where people are not able to spend money on pressure relieving cushions and so on, then don't sit them 8 weeks. Because the tissue, the scar tissue, for it to achieve 70% strength of normal skin takes 1 year. So it will be foolish to make him go and sit before 8 weeks at least, or over, after full healing. But if you have facilities, then the way we used to do it in England was to make a person sit after 3 weeks, when all the sutures are out, no other problems. Start with half an hour of mobilization on a pressure relieving cushion, like a Roho or one of those tea bag cushions and so on. And then slowly increase. Every day you increase by 15 minutes of sitting. Towards the end of 3-4 weeks, they would have sat about 4 hours, 4.5 hours, at which time you discharge them with all the other provisions of pressure relief. If you are sitting on a pressure relieving mattress like Roho, you don't need to do every 15 minutes. If there is no cushion like that, you have to do every 15 minutes. Otherwise, your flap will go necrose. Your flap will necrose after that. Okay? So I think that is the way it is.
Yeah, it depends upon education of the patient. Even you advise them and they don't follow the protocol of 15 minutes, it may be 1 or 2 hours. But we should properly educate the patient. As far as possible, change your cushion and try to follow the principle of weight relieving procedures. That's important. Thank you, sir.
Thank you, sir. I call upon Raji Thomas, madam, to give the memento to